Welcome back to the Deep Dive. This is where we take that pile of source material you've gathered, research notes, articles, and really dig in, pulling out the core knowledge, the key insights, and, well, those moments that just make you go, aha. Today we are diving headfirst, quite literally, into the human head and neck. Just think about it for a second. This relatively compact area holds your brain, the absolute command center for consciousness, thought, emotion, and alongside that, all the incredibly intricate systems that give you sensation, expression, the ability to breathe, to eat. It's just an extraordinary piece of biological engineering, a real masterpiece of connections and vital functions. So our mission today, as we navigate through all this comprehensive material you've provided us with, isn't just about naming parts. No way. We're aiming deeper. We want to really unpack these essential structures, understand how they're all connected in these sophisticated ways, and grasp those critical clinical insights, the kind of insights that, frankly, demand mastery from the absolute best professionals in this field.
We want you to leave not just knowing more, but with a genuine, profound understanding of why all these details matter. Moving beyond the what to the how and the why.
Exactly. And to reach that level, that kind of elite understanding, we need to cover a lot of ground comprehensively. We won't just skim the surface. We'll start with the foundations, exploring the skull's bony architecture, those remarkable protective layers. Then we'll meticulously trace those delicate nerve pathways, every sensation, every command, right down to the twitch of a facial muscle or the complex processing of sight and sound. We'll follow the vital blood vessels, understand how this region gets its nourishment, how waste is cleared. And of course, we'll dissect the intricate sensory organs, your eyes, ears, your nasal passages, your mouth, revealing their incredible sophistication. And throughout this whole deep dive, we'll anchor everything with, well, some surprising facts, definitely crucial clinical applications, and even delve into advanced pathologies, giving you that really high-level, expert grasp of this fascinating area.
All right, let's kick this off just by appreciating the sheer, almost overwhelming complexity here. The head and neck. It's not just complex, it's anatomically dense, intensely integrated. Think of it, like I said, of perfectly fitted, specialized compartments, right? Each doing its crucial job. At the core, obviously, the cranial cavity, that's the big one. The secure vault holding your brain in its protective linings, the meninges, but that's just the start. You've got the ears, mostly housed within the cranial bones, but it's extending out, processing sound, balance. Then the two orbits, perfectly designed, bony sockets for your eyes. Below those, the two nasal cavities for breathing, for smell, and then the oral cavity taste, digestion's starting point. It's just incredibly organized.
It is, and the real elegance is how these compartments work together, serving the head's essential functions. Protection, number one. The head guards the brain, obviously, but also all your special sense systems. Smell in the nasal cavities, vision in the orbits, hearing and balance in the ears, taste in the mouth. Beyond the senses, it also contains the upper ends of your respiratory and digestive tracts. The nasal and oral cavities, again, they're not just holes. They're sophisticated entry points for air and food, designed to start processing things right away. Each cavity perfectly adapted. It shows incredible efficiency, really.
And speaking of protection, the skull. You have to talk about the skull. It's truly nature's masterpiece, isn't it? This bony architecture. We often picture it as this single solid helmet.
Yeah.
But it's actually a collection, a mosaic of many individual bones, and they're linked by these intricate, immovable fibrous joints, the sutures. Once they fully fuse, they provide immense strength, forming this really robust cage around the brain. But it's not just static strength, is it? It's dynamic, especially early on.
That dynamic part is absolutely key, particularly in development. Think about babies. In fetuses and newborns, you see these large, soft, membranous gaps between the big, flat bones of the skull vault. Those are the fontanelles, the soft spots. They have two incredibly ingenious functions. First, they let the baby's head deform slightly. The bones can overlap a bit as it passes through the birth canal, essential for safe delivery. Second, and just as vital, they allow for that massive, rapid brain growth that happens after birth, especially in the first year. Most of these fontanelles close up, ossify within that first year. But the sutures themselves, those fibrous joints, their full ossification into bone actually starts much later, late 20s maybe, and finishes around the 5th decade. So there's this extended period of flexibility for brain development before it all locks down for maximum protection.
Okay, so we have this incredibly protected head, but it's not an island, right?
Yep,
it has
yeah.
to connect to the rest of the body, particularly the trunk. There must be some critical corridors managing all that traffic. What are they?
Excellent point. One of the absolute main corridors is the pharynx, what most people just call the throat. Imagine it like a half cylinder. Muscular walls, fascial walls, a central crossroads. Superiorly, it attaches right up to the base of the skull. Inferiorly, it just blends into the esophagus. And laterally, its edges connect to the nasal cavities, the oral cavities, and the larynx. So, yeah, the nasal cavities, the mouth, the larynx, they all open right into its front aspect, and the esophagus opens from it below. To make sense of this busy hub, we divide it into three parts: nasopharynx behind the nose, oropharynx behind the mouth, and laryngopharynx behind the larynx. It's complex, but very logical traffic control.
And then linking the head and neck down to the chest to the main body trunk, there's another key gateway, the superior thoracic aperture, often called the thoracic inlet. This opening at the base of your neck, like the main highway entrance to a city. Almost everything traveling between the head and the thorax has to pass through here. Imagine it. The trachea, your windpipe, is right up front, just anterior to the esophagus, and the esophagus is just in front of the spine. And then packed in around them, anterior or lateral to the trachea, you've got major veins, major arteries, critical nerves, all squeezed into the surprisingly tight space.
It's incredible spatial efficiency. And right alongside the superior thoracic aperture, on each side, you've also got the axillary inlet. That's the direct gateway into your arm, your upper limb. Here, vital blood vessels like the subclavian artery arc over the first rib, and the complex nerves of the brachial plexus, the network controlling your arm, they pass directly from the neck right into the upper limb here, which explains why that posterior triangle of the neck, a key anatomical area, sits partly over this axillary inlet. It's precisely because it houses and protects those essential nerves and vessels heading into or out of the arm, integrating arm movement and sensation with the neck and head.
With all this complexity and all these connections, having clear landmarks must be absolutely vital for, well, for anyone working in this area. We use specific vertebral levels almost like internal GPS points, right? Like the CIVD level. You can feel that roughly at the top edge of your thyroid cartilage, your Adam's apple. And it's hugely significant because this is precisely where your common carotid artery, that big artery pulsing on each side of your neck, usually bifurcates. It splits into the internal and external carotid arteries. Critical branching point.
Absolutely. And just a bit lower down, at the CVCVI level, you hit another major transition zone. This marks the lower boundary for both the pharynx and the larynx where the throat and voice box end. And at the same time, it's the upper boundary for the trachea and esophagus where the windpipe and food pipe begin. You can actually feel that transition point yourself. It's that little dip between the cricoid cartilage of the larynx and the very first ring of the trachea. For clinicians, these vertebral levels are indispensable. Consistent reference points for exams, procedures, surgical planning, they're the key to visualizing and accessing things you can't actually see directly.
Okay, let's peel back those outer layers now and really venture inside the skull. Explore the intricate inner landscape of the cranial vault, because the floor of the cranial cavity isn't flat, is it? It's sculpted. Divide it into three distinct levels, or depressions, the cranial fossa. Up front, you have the anterior cranial fossa, formed by bits of the frontal bone, the ethmoid bone, and the sphenoid bone. Its floor is like a mosaic, frontal bone at the front and sides, ethmoid in the middle, and the body and lesser wings of the sphenoid making up the back edge. You can see subtle features here too, like the start of the groove for the superior sagittal sinus, a major vein channel. And the boundary with the next fossa, right in the middle, is the front edge of the prechiasmatic sulcus, a little groove connecting the optic canals.
Right. And moving back from there, you enter the middle cranial fossa. This one's mostly built from parts of the sphenoid and temporal bones. Like you said, its front edge is at prechiasmatic sulcus. Its back edges are formed by the front surface of the petrous part of the temporal bone, that really dense, hard part. What's striking here is the shape. The floor and the midline, formed by the sphenoid body, is quite elevated, like a central ridge. But out to the sides, there are these large, deep depressions, sculpted by the greater wing of the sphenoid and the squamous part of the temporal bone. And these depressions are perfectly shaped to hold the temporal lobes of the brain. It's a fantastic example of how the skull's inner form is molded precisely to fit and protect the brain.
And then finally, we reach the posterior cranial fossa. This is the biggest and the deepest of the three, a major chamber. This is the secure housing for some really critical parts of the central nervous system. The brainstem, controlling vital functions like breathing, heart rate, and the cerebellum, the coordinator of balance and movement. It's mainly formed by the temporal and occipital bones, with a little help from the sphenoid and parietal bones. Its front boundaries in the midline are the dorsum sellae, a sort of saddleback projection from the sphenoid, and the clivus, that sloping bony ramp leading down from it, formed by the sphenoid and the base of the occipital bone, leading towards the foramen magnum.
Ugh, the foramen magnum, Latin for great hole. And it is arguably the single most important opening in the posterior fossa. maybe the whole skull base. It's far more than just a hole. It's a vital gateway. This is where the brainstem transitions downwards and continues as the spinal cord. It also allows passage for the vertebral arteries, ascending to supply the brain, the protective meninges wrapping around the spinal cord, and the spinal roots of the accessory nerve, cranial nerve 11. You also find other key features nearby, like grooves for venous sinuses, like the inferior petrosal sinus. It really emphasizes how densely packed and intricate this whole region is.
So inside these fosses, immediately wrapping the brain, we have the meninges, these three protective layers, absolutely critical. The dura mater is the outermost one, tough, fibrous, really robust, and it's actually made of two layers fused together, isn't it? An outer periosteal layer stuck right onto the bone, acting like its perioscum, and an intermeningeal layer.
Exactly. And despite its toughness, the dura needs its own blood supply. It's quite rich, actually. In the anterior fossa, it gets blood from the anterior meningeal arteries, branching off the ethmoidal arteries. In the middle fossa, you've got the middle and accessory meningeal arteries. And in the posterior fossa, the posterior meningeal artery, that's a branch of the ascending pharyngeal artery, plus other branches from occipital and vertebral arteries chip in. Now, here's a critical point for a professional, something you absolutely must know. The middle meningeal artery. It's the biggest of the bunch. A major branch of the maxillary artery, it enters the middle fossa through the foramen spinosum and splits into anterior and posterior branches. This artery is hugely important clinically. Why? Because tearing it is the classic cause of an epidural hematoma, a very dangerous bleed. And the dura isn't just inert, it's innervated too, by small branches from all three parts of the trigeminal nerve, the vagus nerve, and upper cervical nerves. That's why dural irritation or stretching causes those severe headaches.
Okay, moving inwards from the dura, we find the arachnoid mater. Much thinner, more delicate this time, a vascular too, I think. It lines the inner surface of the dura, but, and this is key, doesn't stick tightly to the brain itself. Instead, it sends down these delicate web-like strands, the trabeculae, across the subarachnoid space, connecting down to the innermost layer, the pia mater. A key difference. The arachnode doesn't dip into all the little grooves and fissures of the brain surface, right? Except for the big one, the longitudinal fissure between the hemispheres.
Correct. And that innermost layer is the pia motor, the most delicate of the three. It directly, intimately covers the brain, hugs every contour, follows every groove, dives into every fissure. It's so thin and tightly bound, it actually gives the brain that shiny look. Together, the arachnoid and pia are often called the leptomeninges, thin meninges, distinguishing them from the tough dura, the pachymeninx. That distinction matters clinically, especially with infections like meningitis, which specifically target these inner two layers.
So these layers provide protection, but the spaces between them, some real, some potential, become incredibly significant when things go wrong, like with trauma. Start outside the dura. The extradural or epidural space is technically potential space, right, between the dura and the skull bone. Normally they're stuck pretty tight, but a head injury, a significant blow, can rupture a vessel, usually an artery, and force that space open with blood, creating an actual space. And the bleeding here is typically arterial, usually from a torn meningeal artery, and as you just highlighted, the middle meningeal is the classic culprit, or sometimes from a torn dural venous sinus. The result is an extradural hematoma. And the classic story, the one everyone learns, is blow to the head, maybe a brief blackout, then a period where the person seems okay to lucid interval. It can last hours, but then, rapid decline, drowsiness, unconsciousness, pupil changes, potentially fatal if not treated urgently. A true emergency.
Absolutely. Then, moving inward, we have the subdural space. Again, anatomically, not really a true space normally. It's created when those delicate bridging veins, the cerebral veins crossing from the brain surface to drain into the dural venous sinuses, get torn. Blood then collects between the dura and the arachnoid mater, forming a subdural hematoma. This is venous bleeding, so it's typically slower, more insidious than an arterial bleed. Patients most at risk: the very young, whose brains are maybe more mobile, and the elderly. In older adults, brain atrophy, a bit of shrinkage, increases the space and stretches those bridging veins, making them more vulnerable to tearing, sometimes even from a minor bump or jolt. The history is often less dramatic, maybe a trivial fall weeks ago, followed by a slow, gradual decline in consciousness or subtle personality changes, can develop over days or even weeks, much harder to spot sometimes.
And then there's the subarachnoid space. This one is a true space, normally full of cerebrospinal fluid, CSF. A subarachnoid hemorrhage here is particularly bad news. It can happen after severe trauma, sure. But the classic cause, often catastrophic, is a ruptured brain aneurysm, usually one of those weak spots in the circle of Willis at the base of the brain. And the presentation is dramatic. Sudden, intense headache, often described as the worst headache of my life, a thunderclap headache, frequently with neck stiffness from the blood irritating the meninges and vomiting. Unmistakable, usually.
And speaking of CSF, let's delve into that system. Cerebrospinal fluid, its production, its flow, its function, and what happens when it goes wrong. CSF isn't static, it's constantly being made. Secreted by specialized tissue called the choroid plexus, found in the ventricles, the lateral, third, and fourth ventricles deep inside the brain. From the two lateral ventricles, it flows through the interventricular foramina, the foramina of Monro, into the single third ventricle. Then through the narrow cerebral aqueduct of Sylvius into the fourth ventricle. And finally, from the fourth ventricle, it escapes into the subarachnoid space, that real space surrounding the brain and spinal cord. It gets out through three openings, the midline foramen of Magendie and the two lateral foramina of Luschka. Once it's in the subarachnoid space, it circulates all around the brain and down around the spinal cord.
And getting rid of it, the reabsorption, is just as vital for keeping things balanced, right? It gets absorbed back into the bloodstream through these specialized structures called arachnoid granulations. They poke up into the dural venous sinuses. Our bodies are incredibly productive, making about half a liter of CSF every day. So this whole volume has to be constantly cycled, constantly reabsorbed. When that balance gets disrupted, too much production, blocked flow, poor reabsorption, you get serious problems.
One of the biggest is hydrocephalus. Literally water on the brain. It's basically an abnormal buildup of CSF, causing the ventricles to swell, to dilate, often due to a blockage somewhere in the flow pathway, but it can also happen from overproduction or, crucially, failure of reabsorption. A common cause in adults, tying back to what we just discussed, is blood in the subarachnoid space after a hemorrhage interfering with those arachnoid granulations doing their job. Treatment often involves surgically placing a shunt, a tube, to drain the excess fluid and relieve the pressure. Diagnosis relies heavily on CT and MRI scans to see the dilated ventricles, pinpoint the blockage if there is one, and rule out other things like brain atrophy.
Another issue, which can be really debilitating, is a CSF leak, where the fluid actually escapes from the subarachnoid space, usually through a tear in the dura mater. It can happen after procedures like spine surgery, an epidural, a lumbar puncture. But fascinatingly, it can sometimes happen spontaneously with no obvious cause. Symptoms can be tricky. Persistent dizziness, nausea, fatigue, sometimes a weird metallic taste, even facial weakness or double vision can be tough to diagnose. And then, of course, meningitis. Thankfully rarer now, but incredibly serious. An infection of the leptomeninges, the arachnoid, and pia. Infection can get in via the bloodstream or directly through trauma, or critically spread from nearby infections, like severe sinusitis potentially eroding through the cribriform plate from the nasal cavity. Needs immediate aggressive IV antibiotics. Life-threatening.
Okay, let's switch gears slightly and navigate the vascular highways. The arteries supplying the brain. This is absolutely vital territory. The main feeds come from two pairs of arteries. First, the two vertebral arteries. They come up through the neck, enter the skull through the foramen magnum, and then beautifully merge together just below the pons to form the single basilar artery. Second, the two internal carotid arteries. They enter the skull base through the carotid canals on each side. These four vessels are the brain's primary lifelines.
And here's where the design gets really clever. These major arteries connect up at the base of the brain to form the circle of Willis, a critical ring of arteries providing backup, collateral circulation. It's brilliant redundancy. This circle is formed by the posterior cerebral arteries branching off the basilar artery, the posterior communicating arteries linking the internal carotids to the posterior cerebrals, the anterior cerebral arteries coming off the internal carotids, and the anterior communicating artery, which connects the two anterior cerebral arteries, completing the loop. This whole setup is a crucial safety net. If one of the main feeder arteries gets blocked or narrowed, this circle can often reroute blood flow, potentially saving critical brain tissue. It's amazing self-preservation design.
And the venous drainage is just as elaborate and essential. It starts deep inside with tiny veins that merge into larger cerebral, cerebellar, and brainstem veins. But these veins don't just drain like typical body veins. They empty into the dural venous sinuses. These sinuses are unique. Their channels actually formed between the layers of the dura mater, lined with endothelium. Essentially, veins built into the dura itself. These sinuses collect all the venous blood and eventually funnel it down into the internal jugular veins, which then carry it out of the skull. Key sinuses include the big superior sagittal sinus running along the top midline, the inferior sagittal straight transverse, the incredibly complex cavernous sinuses, intercavernous, venoparietal, superior petrosal sinuses, quite a network. The superior sagittal sinus, for example, not only collects venous blood, but also plays that key role in absorbing CSF via the arachnoid granulations.
Those cavernous sinuses you mentioned, they sound particularly important and complicated. They're paired, right? Big venous channels on either side of the sphenoid bone body. And they're like major intersections, aren't they?
packed with vital structures. The internal carotid artery actually passes through the sinus. The abducent nerve, cranial nervous eyes, controlling sideways eye movement, is also right inside it. And then embedded within its lateral wall, running from top to bottom, you've got the oculomotor nerve, the trochlear nerve, and the first two divisions of the trigeminal nerve, the ophthalmic V1 and maxillary V2. Plus, the two cavernous sinuses are connected across the midline by the intercavernous sinuses. So any problem there, it's infection, thrombosis, tumor, can affect a whole host of critical nerves and the carotid artery itself. Huge neurological implications.
Definitely. And besides those main cerebral veins and dural sinuses, there are a couple of other venous systems worth noting. The diploic veins form a network within the spongy bone of the skull vault itself, eventually draining into the dural sinuses. And then you have the emissary veins. These are really interesting. They pass directly through foramina in the skull, connecting veins outside the skull in the scalp and face with the dural venous sinuses inside. Now, here's your critical clinical alert, something every professional needs tattooed on their brain. Emissary veins generally lack valves. Unlike most veins, this makes them a direct two-way street, an unprotected pathway. Infections from the scalp or face a bad pimple, a sinus infection can track straight along these veins into the cranial cavity, bypassing all the normal defenses, leading to potentially devastating intracranial infections like meningitis or brain abscesses. A fundamental pathway of infection spread to understand.
Okay, let's shift our focus outwards now to the face. It's so much more than just, well, our face. It's our identity, our main communication tool, a huge sensory hub. Just looking at the surface, you can easily spot key features. The palpebral fissures, the gaps between your eyelids, the oral fissure between your lips, the nostrils openings to the nasal cavities, and we use palpable landmarks all the time to orient ourselves. The bony ridges under your eyes, the inferior orbital margins, the top edge of your ear canals, the external acoustic metisses, which help define that Frankfurt plane used in anthropology and dentistry, the head of your mandible where your jaw hinges, prominent cheekbones, the zygomatic arching bone, the mastoid process bump behind the ear, the external occipital protuberance at the back of your skull.
And getting more specific, you can feel the bony ridges above your eyebrows, the superciliary arches, usually more prominent in men. Between them, that slight dip is the glabella. Then there's the supraorbital foramen, or notch, that little hole or dip on the upper rim of your eye socket, letting nerves and vessels through. The mandible itself, the lower jaw, is packed with features. The main body and the upright rami, the alveolar part holding the teeth, the mental protuberance forming the chin, the mental foramen on the side for the mental nerve, the oblique line for muscle attachment, and those crucial processes at the back, the condylar process that articulates with the skull, and the coronoid process where the temporalis muscle attaches. Each little bump and hole has a purpose.
Now, the muscles of facial expression. These are fascinating. They're not just for smiling or frowning. They're fundamental to how we communicate emotion, our identity. What's unique about them? Well, they all arise from the same place embryologically, the second pharyngeal arch, which means they all share the same nerve supply, branches of the facial nerve, cranial nerve 7. And their key characteristic: they sit in the superficial fascia, just under the skin. They mostly originate from bone or fascia, but crucially, they insert directly into the skin. That skin attachment is what lets them pull on our features, create expressions, and beyond just expression, they also act as sphincters and dilators for our eyes, nose, and mouth.
We can group them by function to make sense of them.
The orbital group,
Orbicularis oculi, that big circular muscle around the eye.
it has parts for gentle blinking and for squeezing the eyes shut tightly. Then the corrugator supercilii pulls the eyebrows down, and in the frowning muscle, the nasal group, nasalis muscle compresses and dilates the nostrils. Procerus helps frown. Depressor septi nasi affects the nasal septum. And the oral group is huge, giving us incredible lip and mouth control. Orbicularis, oris, the main muscle around the mouth, closes and protrudes the lips, vital for speech, eating, kissing. Then there's the buccinator, deeper in the cheek, essential for pressing the cheek against the teeth, keeping food where it should be during chewing, and for actions like blowing out your cheeks. Plus a whole host of others. Depressor anguli oris, pulling down the mouth corners, depressor labii inferioris for the lower lip, mentalis puckering the chin, risorius for a sort of smirk, zygomaticus major and minor, the main smiling muscles pulling the corners up and out, and several levator muscles lifting the upper lip and mouth corners. Many of these oral muscles actually meet and interlace at a fibrous point, just lateral to the corner of the mouth, the modiolus. A little hub allowing for coordinated movements. And don't forget related muscles like the platysma sheet in the neck, the little auricular muscles around the ear, and occipitofrontalis moving the scalp and forehead, all part of this facial nerve team.
And clinically, understanding these muscles leads straight to Botox. derived from that Clostridium botulinum toxin, right? Its magic is blocking the neuromuscular junction, stopping acetylcholine release, causing targeted muscle relaxation. And its uses go way beyond wrinkles, treating strabismus, crossed eyes, by injecting eye muscles, blepharospasm, uncontrolled blinking, various spastic muscle conditions, even overactive bladder, and hyperhidrosis, excessive sweating. It's a powerful therapeutic tool, all based on precisely targeting these muscles, a real testament to applying detailed neuroanatomy.
Now let's focus on the parotid gland, a major player in saliva productions. It's the largest salivary gland, sitting just in front of and below the lower half of the ear, covering parts of the mandible ramus. But what makes it so surgically important, so critical, is its incredibly close relationship with major nerves and vessels that either run right through it or are very deeply related to it.
Absolutely critical point. First and foremost, the facial nerve, cranial nerve 7. After it exits the skull via the stylomastoid foramen, it plunges almost immediately into the parotid gland. Inside the gland, it typically splits into upper and lower trunks, which then fan out into those 5 crucial terminal branches: temporal, zygomatic, buccal, marginal mandibular, and cervical. These then emerge from the gland's edges to supply all those facial muscles we just discussed. This intimate relationship makes parotid surgery, especially tumor removal, exceptionally challenging. The surgeon has to meticulously dissect and identify every single branch to avoid causing devastating facial paralysis. It requires elite skill and anatomical knowledge.
And it's not just the nerve. The external carotid artery, a major neck artery, also passes into or deep to the gland. Inside or near the gland, it gives off the posterior auricular artery and then divides into its final 2 branches, the maxillary and superficial temporal arteries.
And thirdly, the retromandibular vein, which drains large parts of the face and scalp, is actually formed within the parotid gland itself by the joining of the superficial temporal and maxillary veins. So yeah, a critical nerve, a major artery, and a major vein are all tangled up with or passing through this one gland.
What about its own nerve supply? For sensation, it gets input from the auriculotemporal nerve, a branch of the mandibular nerve, V3, so inflammation hurts. But for making saliva its secretomotor function, the pathway is a bit more indirect, involving parasympathetics. Preganglionic fibers start in the glossopharyngeal nerve, travel to the auricular ganglion to synapse, and then the postganglionic fibers cleverly hitchhike along the auriculotemporal nerve to reach and stimulate the parotid gland.
Clinically, parotid tumors aren't uncommon. Thankfully, most are benign things like pleomorphic adenomas, adenolymphoma, and often affect the superficial part. But, as we've stressed, the absolute key in managing them is precisely defining the tumor's relationship to those facial nerve branches before surgery. The #1 goal during resection is complete tumor removal while meticulously preserving facial nerve function. Any compromise is catastrophic for the patient. It really underscores the need for that elite anatomical understanding in practice.
Okay, let's break down the face's overall sensory and motor innervation clearly. Sensation, touch, pain, temperature, that's almost entirely the trigeminal nerve's job. Cranial nerve V. It divides into 3 main branches, each covering a distinct territory. V1, the ophthalmic nerve, exits through the superior orbital fissure. Its branches supratrochlear, supraorbital, lacrimal, infratrochlear, external nasal cover the forehead, upper eyelid, top of the nose, anterior scalp.
And what's fascinating, really useful for diagnosis, is how these 3 divisions precisely map the face, almost like dermatomes, V1 on top. Then V2, the maxillary nerve, exits via foramen rotundum. Its branches infraorbital, zygomaticofacial, zygomaticotemporal, supply the lower eyelid, the cheek, the upper lip, middle territory. And finally, V3, the mandibular nerve, exits via foramen ovale. Its branches auriculotemporal, buccal, mental cover the lower face, parts of the ear and temple, the lower lip, the chin, lower territory. This precise mapping means neurological issues affecting one branch cause very predictable sensory loss, invaluable for pinpointing problems.
And motor supply to the face. That's overwhelmingly the facial nerve, cranial nerve 7, as we keep coming back to. After exiting the stylomastoid foramen, but before diving into the parotid, it gives off a few branches. The posterior auricular nerve to occipitalis muscle and ear muscles, and branches to the posterior belly of digastric and the stylohoi muscle. Then, as we know, it enters the parotid, and its terminal branches emerge. Temporal, zygomatic, buccal, marginal mandibular, cervical, orchestrating all those facial expressions.
Now, the blood supply and lymphatics of the face and scalp. Very rich arterial supply. Comes from 2 main sources. Primarily, branches of the external carotid artery. The facial artery winding up towards the eye, ending as the angular artery. The superficial temporal artery, and branches from the maxillary artery, like the infraorbital and buccal. But also, branches from the ophthalmic artery, which comes from the internal carotid, contribute too, specifically the supratrochlear and supraorbital arteries. Venous drainage largely follows the arteries, collecting into the facial vein, the retromandibular vein, and eventually draining into the internal and external jugular veins in the neck.
And the lymphatic drainage, also very organized. Lymph generally follows the arteries to specific node groups, like the submandibular nodes getting lymph from the lower face, gums, teeth, tongue. The preauricular and parotid nodes draining the front of the ear, side of the scalp, upper face, eyelids, cheeks. This drainage pattern is crucial for tracking the spread of infections, and especially for staging cancers in this region. Knowing where things drain is key.
And finally, let's not forget the scalp itself. Remember the acronym SCLP, essential for its 5 layers. S, skin. C, connective tissue, dense, fatty, and critically holds blood vessels tightly so they don't retract well when cut. A, aponeurosis, the epicranial aponeurosis, that tough tendinous sheet connecting the frontalis and occipitalis muscles. L, loose connective tissue allows scalp movement, but also lets infections spread easily underneath. P, pericranium, the periosteum covering the skull bones.
Scalp innervation is also segmented. In front of the ears and up to the top vertex, it's mostly trigeminal nerve branches, V, supratrochlear, supraorbital, zygomaticotemporal, auriculotemporal. Behind the ears and vertex, it's cervical nerves, greater occipital C2, lesser occipital C2, greater auricular CD through 3, third occipital C.
And the blood supply to the scalp is incredibly rich, as we hinted. Branches from both internal carotid via ophthalmic supratrochlear, supraorbital, and external carotid, superficial temporal, posterior auricular, occipital. Which brings us to that critical clinical insight. Scalp cuts bleed a lot, profusely. It's not just the rich supply, it's that dense connective tissue layer, the C in a P. It holds the vessel walls open, prevents them from constricting and closing off properly when cut. So even a seemingly small scalp laceration can lead to significant, alarming blood loss if you don't apply pressure quickly, something every first responder knows well.
Okay, let's move to those incredible sensory gateways now, starting with the orbit, that intricate bony socket protecting our precious eyesight. The orbit's framework is really complex, isn't it? A pier in shape, precisely engineered. The roof is mainly frontal bone, with a bit of the sphenoid's lesser wing. The medial wall, the inner wall, is fascinating, a mosaic of 4 bones: maxilla, lacrimal, ethmoid, and sphenoid. The ethmoid often contributes the most, with its thin orbital plate covering the ethmoidal air cells. And this wall has important holes: the anterior and posterior ethmoidal foramina for nerves and vessels, and the groove for the lacrimal sac, part of the tear drainage system.
Then the floor, the inferior wall, is mainly the orbital surface of the maxilla, with small bits from the zygomatic and palatine bones. Interestingly, this floor doubles as the roof of the maxillary sinus below it, a shared partition. And the lateral wall, providing strong side protection, is formed by the zygomatic bone and the sphenoid's greater wing. These walls aren't totally sealed, though. There are key openings. The optic canal, obviously, for the optic nerve and ophthalmic artery. The superior orbital fissure, a big gap letting through multiple cranial nerves for eye movement, 3, 4, 6, and sensation, V1, plus veins. And the inferior orbital fissure connecting to other facial spaces.
And inside the orbit, besides bone, there are important fascial structures. The periorbita, basically the periosteum lining the bones, the orbital septum helping form the eyelids, and the common tendinous ring, that fibrous ring at the back where the rectus high muscles originate. Clinically, orbital fractures are pretty common, especially involving the thinner floor or medial wall. Those floor fractures, the blowout fractures, can be nasty. They can trap the inferior oblique muscle, stopping it from moving properly. Result: the eye can't look upwards fully, leading to double vision, diplopia, and medial wall fractures involving the ethmoid. You might see air in the orbit on an X-ray or CT. Why? Because the fracture breaks into the ethmoidal air sinuses, creating a connection. Shows how interconnected these spaces really are.
Now, the eyelids themselves, delicate, yes, but incredibly effective protectors. They're layered structures. Skin, subcutaneous tissue, muscle, orbicularis oculi, orbital septum, the tarsal plate, dense connective tissue giving shape, and the conjunctiva lining the inside. The space between the open lids is the palpebral fissure, and that conjunctiva, the thin membrane, lines the back of the lid, then reflects onto the eyeball itself, covering the white sclera, forming the conjunctival sac. And eyelids have specialized glands, right? Crucial for eye health. The tarsal glands, or meibomian glands, are embedded in those tarsal plates. They secrete an oily layer for the tear film, stopping tears evaporating too quickly, preventing dry eye. If they get blocked or inflamed, you get a chalazion, usually painless lump. Then associated with the eyelashes, you have other sebaceous and sweat glands. If they get blocked or infected, that's a hordeolum, or stye, usually painful.
Eyelid innervation is complex too. Sensation comes mostly from branches of the ophthalmic nerve, V1, supraorbital, supratrochlear, infratrochlear, lacrimal, plus the infraorbital branch of the maxillary, V2, for the lower lid. But motor control involves three different nerves working together. Facial nerve closes the eye tightly via orbicularis oculi. Oculomotor nerve lifts the upper lid via levator palpebrae superioris, that's a voluntary opening. And sympathetic fibers control the superior tarsal muscle, giving a little bit of involuntary lift.
Which explains ptosis, the drooping eyelid. The cause depends on which nerve is affected. Complete ptosis can't open the eye voluntarily. That points to an oculomotor nerve problem affecting levator palpebrae superioris, serious sign. But partial ptosis, a slight droop, that often suggests a problem with the sympathetic nerve supply to that superior tarsal muscle, like in Horner syndrome. Remember, that collection of signs: pupil constriction, partial ptosis, lack of sweating caused by disrupted sympathetic nerves to the head, often due to something like a lung tumor pressing on the sympathetic chain. Differentiating those is key.
Then there's the lacrimal apparatus, the tear factory and drainage system, essential for lubricating, nourishing, protecting the eye surface. It includes the lacrimal gland itself, its ducts, the tiny lacrimal canaliculi, the lacrimal sac, and the nasolacrimal duct. The lacrimal gland sits up in the outer superior part of the orbit. Often divided into two parts by the levator muscle tendon, it continuously secretes tears, bathing the eye.
And the drainage is so efficient. Blinking sweeps the tears medially towards the inner corner, into the lacrimal lake. From there, they enter tiny openings, the puncta, on little bumps called papillae, one on each lid margin. These lead into the lacrimal canaliculi, which drain into the lacrimal sac, tucked in its bony groove. Finally, the tears flow down the nasolacrimal duct, through a bony canal, and empty right into the nasal cavity under the inferior concha. That's why your nose runs when you cry. A constant vital flow keeping eyes healthy.
The extrinsic eye muscles give us that incredible range of precise, coordinated eye movements. Tracking, reading, focusing. There are 7 in total. 4 rectus muscles, superior, inferior, medial, lateral, mostly straight movements, up, down, in, out. 2 oblique muscles, superior and inferior, more rotational movements. And the 7th is levator palpebrae superioris, lifting the eyelid, which we already mentioned. The 4 rectus muscles share a common origin point at the back of the orbit, that common tendinous ring.
And their innervation, a classic mnemonic, LR6 says so for. Let's keep it straight. Lateral rectus moves eye outwards. Abduction is innervated by the abducent nerve, cranial nerve physics. Sphere Greek depresses and rotates eye inwards, is innervated by the trochlear nerve, cranial nerves to vest. And all the rest, superior rectus, inferior rectus, medial rectus, inferior oblique, and levator palpebrae superioris, are innervated by the oculomotor nerve, cranial nerve 3. Together they allow adduction, abduction, elevation, depression, internal and external rotation. Amazing versatility.
Clinically, if one of these muscles or its nerve gets paralyzed, it's a big deal. Can happen from brainstem issues, direct nerve injury, tumors, trauma. The main symptom is usually double vision, diplopia, because the eyes aren't moving together. For instance, we mentioned the inferior oblique getting trapped in an orbital floor fracture. That restricts upward movement, causing diplopia specifically when trying to look up. A clear sign an elite professional links straight back to the anatomy.
Okay, the eyeball itself, the structure that actually detects light. How's it put together? 3 main layers, right? Outer fibrous layer, the tough white sclera, and the clear cornea at the front. Middle vascular layer, the via, includes the choroid, ciliary body, and the iris, the colored part, and the inner layer, the retina, the light-sensing tissue. Inside there are chambers: anterior chamber, cornea to iris, posterior chamber, iris to lens, and the big vitreous chamber behind the lens, filled with vitreous humor.
And in those front chambers, you have aqueous humor.
Right.
That clear fluid, it's made by the ciliary body, flows from the posterior chamber through the pupil into the anterior chamber. Then it drains out through the trabecular meshwork into the scleral venous sinus, the canal of Schlemm, at the angle where the cornea meets the iris. Its job: supplying nutrients to the cornea and lens, which have no blood vessels of their own. And critically, maintain the eye's internal pressure, the intraocular pressure, which brings us to that crucial clinical alert: glaucoma. Increased eye pressure, usually because that aqueous humor drainage is blocked or slow. Untreated, it damages the optic nerve, causes vision loss. Regular eye pressure checks are vital.
And the retina, the inner layer. That's where light gets converted to nerve signals. It has 2 parts, an outer pigmented layer and an inner neural layer. It's the neural layer that comes away in a retinal detachment. Serious stuff. At the back, you can see the optic disc. That's where the optic nerve fibers bundle together and leave the eye. It looks lighter through an ophthalmoscope. Branches of the central retinal artery spread out from here. And because there are no photoreceptors right on the disc, it's our natural blind spot. Just lateral to the disc is the macula lutea, a yellowish spot with a central pit, the fovea centralis. The fova is where our vision is sharpest, most detailed. Thinnest retina, packed with cone cells for color and fine detail.
And the tool we use to see all this is the ophthalmoscope. Direct visualization of the back of the eye. You can examine the optic disc, check the retinal blood vessels, look at the fovea, detect signs of optic nerve disease, high blood pressure, diabetes, glaucoma, retinal detachment. It's an indispensable diagnostic tool for assessing eye health and even systemic diseases.
The optic nerve itself, cranial nerve too, it's unique, isn't it? Not really a typical peripheral nerve. More like an extension of the brain itself, carrying all that visual information from the retina back towards the visual cortex. And because it's part of the brain, it's wrapped in the same meningeal layers, dura, arachnoids, fia, including that subarachnoid space filled with CSF, extending right up to the back of the eyeball.
And that direct connection is clinically crucial. Think about pateledema. If pressure inside the skull increases from a tumor, swelling, whatever that pressure gets transmitted along the subarachnoid space surrounding the optic nerve, this increased pressure can squash the veins, draining the retina, causing fluid to back up and the optic disc to swell. That's papilledema. Seeing a swollen optic disc on ophthalmoscopy is a major red flag for raised intracranial pressure. It needs urgent investigation. Also worth mentioning briefly, the ciliary ganglion, a tiny parasympathetic ganglion near the optic nerve, is where nerve fibers controlling the pupil and lens focus from the oculomotor nerve, so a synapse, before going into the eyeball. Sympathetic and sensory fibers pass through it too, a little nerve relay station for eye function.
Okay, let's switch senses. To the ear, sound capture and balance. Starting outside with the external ear, its job is to collect sound waves. The visible part is the auricle, or pinna, cartilage mostly, with all these unique folds and curves, helix, antihelix, concha, tragus, antitragus, and the soft lobule at the bottom. That complex shape helps funnel sound into the ear canal, and its nerve supply is surprisingly diverse, reflecting its development: great auricular nerve, lesser occipital, auriculotemporal branch of E3, even small bits from the vagus X, and facial nerves.
Then the external acoustic meatus, the ear canal itself, guides the sound waves inwards, part cartilage, part bone. Its nerve supply is mainly the auriculotemporal nerve, V3, for the front and top walls, and the auricular branch of the vagus nerve for the back and bottom walls, plus a tiny bit from the facial nerve. That vagal innervation is interesting. It explains why poking around in your ear canal, like with an otoscope or a cotton swab, can sometimes make people cough. A reflex arc via the vagus.
Moving inwards, we hit the middle ear, an air-filled space, vital for transmitting sound efficiently. It starts with the tympanic membrane, the eardrum. Thin, oval membrane separating the external canal from the middle ear cavity. You can see landmarks on it. The umbo, where the malleus handle attaches, and that cone of light reflection. It has different parts, too, pars flaccida and pars tensa. The middle ear space itself is the tympanic cavity, plus an upper bit called the epitympanic recess.
And it's not sealed off. It connects backwards to the mastoid air cells in the bone behind the ear, and crucially, it connects forwards to the nasopharynx via the pharyngotympanic tube, the eustachian tube. That tube is essential for equalizing air pressure on both sides of the eardrum, why your ears pop when you change altitude. And inside the middle ear cavity, the three tiniest bones in the body, the auditory ossicles, malleus, hammer, imbutucus, anvil, and stapes, strip. They form a linked, movable chain. Malleus attached to the eardrum, and aeducus bridging malleus to stapes, and the stapes fitting perfectly into the oval window and opening to the inner ear. They act like a lever system, amplifying the vibrations.
And there are tiny muscles in there, too. Tensor tympani and stapedius. Tensor tympani, innervated by the mandibular nerve, V3, pulls the malleus inwards, tensing the eardrum. Stapedius, innervated by the facial nerve, pulls the stapes backwards, dampening its movement. They protect the inner ear from loud noises, right? A protective reflex. The lining of the middle ear and eustachian tube gets its nerve supply from the tympanic plexus, mostly from the glossopharyngeal nerve, via its tympanic branch, plus some sympathetic fibers.
Right. And there's also the lesser petrosal nerve, which carries preganglionic parasympathetic fibers away from that tympanic plexus, originating from Lycax. These fibers head to the otic ganglion, where they synapse, and then postganglionic fibers go on to innervate the parotid gland for salivation. A neat little connection.
And finally, the internal ear, deep inside the petrous temporal bone, the hub for both hearing and balance. It's a complex system of bony cavities. The bony labyrinth, which contains a series of delicate membranous ducts and sacs, the membranous labyrinth. The bony labyrinth has three main parts. The vestibule is the central chamber, containing the utricle and saccule, sensors for linear acceleration and gravity. The vestibular aqueduct leaves from here. Then the 3 semicircular canals, anterior, posterior, lateral, projecting out at right angles. They detect rotational head movements via swellings called ampullae. And third, the cochlea, that spiral snail shell shape, purely for hearing.
Inside the bony cochlea are fluid-filled channels, the scalae. Scala vestibuli connects to the vestibule. Scala tympani ends at the round window, another membrane-covered opening to the middle ear. These two scalae connect at the cochlear apex via the helicotrema. There's also a tiny cochlear canaliculus linking the cochlear fluid space to the subarachnoid space. The bony labyrinth is filled with perilymph. The membranous labyrinth inside it contains endolymph, a fluid with a different chemical makeup, vital for function. And the nerve serving all this is the vestibulocochlear nerve, cranial nerve 8. Two distinct parts. Vestibular component for balance from the vestibular ganglion, cochlear component for hearing from the spiral ganglion within the cochlea's core.
So how does hearing actually work in there? It's a cascade, isn't it? Eardrum vibrates. Ossicles amplify and transmit the vibration. States pushes on the oval window. Creates a pressure wave in the perilymph fluid inside the cochlea. This fluid wave travels through the scalae and makes the basilar membrane vibrate. Stimulates the tiny hair cell receptors in the spiral organ of Corti, sitting on that membrane. Hair cells generate nerve signals. Cochlear nerve picks them up, sends them to the brain for interpretation as sound. Phew, it's an incredible conversion of mechanical energy to electrical signals. Okay, let's move into those vital passageways connecting the head down towards the body, starting with the pharynx to the throat. A truly critical crossroads for both air and food. It's basically a muscular fascial tube like a half cylinder, a central hub in the neck. We divide it based on what's in front of it. Nasopharynx behind the nasal cavities. Contains the adenoids, pharyngeal tonsil, and the openings of the eustachian tubes with those little bumps, torus tubarius and torus levatorius.
Below that, the oropharynx, behind the oral cavity. It goes from the soft palate down to the epiglottis. You see the palatine tonsils in its sidewalls between the palatoglossal and palatopharyngeal folds, often get sore throats there. And the lowest part is the laryngopharynx. Extends from the top of the epiglottis down to where the esophagus begins, around C6 level. The entrance to the laryngeal inlet, opens into its front wall, and on either side of the inlet are the piriform fossae little channels that guide food and liquids safely down towards the esophagus, bypassing the airway opening.
And acting like a crucial valve in all this is the soft palate, that muscular flap at the back of the roof of your mouth. Its main job is to lift up and back during swallowing, right? To seal off the nasopharynx. Stops food going up your nose. Hugely important. It can also move down to help close off the oral cavity. And the pharynx has muscles too. Constrictor superior, middle, inferior, forming the outer walls, overlapping like stacked cups, blending into the esophagus, mostly run by the vagus nerve via the pharyngeal plexus, and longitudinal muscles, stylopharyngeus, salpingopharyngeus, palatopharyngeus, which lift the pharynx up during swallowing. Stylopharyngeus is special, innervated by glossopharyngeal, IX. The others mostly by vagus X.
And this leads to that beautiful coordination of swallowing. It's amazing. Normally breathing, your airway's wide open, air flows freely, but when you swallow, it's a rapid-fire sequence. Soft palate snaps up, seals the nasopharynx, epiglottis folds down like a lid, covers the laryngeal inlet. The whole larynx gets pulled up and forwards, tucking under the tongue root. All this creates a protected pathway for food to shoot past the airway opening and straight into the esophagus, which highlights that fundamental truth. You literally cannot breathe and swallow simultaneously. The airway is actively sealed off for protection.
Okay, from the pharynx down into the airway proper, the larynx, the voice box. But much more than that, it's the airway's guardian. It's the top part of the lower airway. Connects to the trachea below and the pharynx behind and above. Its framework is made of cartilage. 3 big unpaired ones. Cricoid cartilage, like a signet ring down at C6 level. Thyroid cartilage, the largest, forms the Adam's apple, laryngeal prominence, more angled in men. And the leaf-shaped epiglottis, the airway protector during swallowing.
Plus 3 pairs of smaller but vital cartilages. The pyramid-shaped arytenoids sitting on the cricoid, with crucial processes for muscle and vocal fold attachment, and the tiny corniculate and cuneiform cartilages. These cartilages connect via joints and ligaments, allowing precise movements. Cricothyroid joints let the thyroid tilt on a cricoid. Stretching the vocal folds changes pitch. Cricoarytenoid joints let the arytenoids slide and rotate, opening and closing the gap between the vocal folds, the glottis. And there's the median cricothyroid ligament connecting cricoid and thyroid at the front. Inside, the laryngeal cavity is complex. The inlet, vestibule, ventricle, the rima glottitis, the actual gap between vocal folds, and the infraglottic space leading to the trachea.
And the intrinsic muscles of the larynx that give us our voice protect the airway. What's key for professionals to remember about their innervation? Almost all of them are supplied by the recurrent laryngeal nerve from vagus X, right? With one critical exception, the cricothyroid muscle. That one's innervated by the external laryngeal nerve from the superior laryngeal branch of vagus X, and its job is to tense the vocal folds, pitch control.
Exactly. And among those intrinsic muscles, one pair is uniquely life-saving. The posterior cricoarytenoids. They are the only muscles that pull the vocal folds apart abduction, opening the rima glottis. Absolutely essential for breathing. If they're paralyzed, the airway closes. In contrast, the lateral cricoarytenoids pull the folds together adduction, closing the glottis for voice production, effort closure, and airway protection during swallowing. The transverse arytenoid also helps adduct, and the thyroarytenoid vocalus muscles fine-tune tension and act as sphincters.
Which leads to a critical clinical procedure, cricothyrotomy. That emergency airway access. If someone's airway is blocked above the vocal cords and you can't intubate, you go through the median cricothyroid ligament, chosen because it's relatively superficial, easy to find, and usually doesn't have major structures overlying it. A rapid, life-saving move based purely on knowing that anatomy.
The overall nerve supply is complex. Superior laryngeal nerve from vagus X splits. Internal branch gives sensation above the vocal folds, triggers cough. External branch supplies only the cricothyroid muscle. Then the recurrent laryngeal nerves, also from vagus X. They have that tricky path, right loops under subclavian artery, left loops under aortic arch, then both run up in the groove between trachea and esophagus. They provide sensation below the vocal folds and motor supply to all other intrinsic laryngeal muscles except cricothyroid, which leads to that huge clinical alert. Damage to the recurrent laryngeal nerve, very possible during thyroid surgery due to its close proximity, causes vocal cord paralysis on that side. Unilateral damage equals hoarse voice. Bilateral damage, potentially catastrophic airway obstruction, a major surgical risk requiring meticulous technique.
Okay, shifting to the nasal cavities. Not just for breathing, but air conditioning and smell centers too. Their job. Uppermost part of the respiratory tract. House olfactory receptors, warm and humidify inhaled air, trap dust and particles with hairs and mucus. Structurally, they're long, wedge-shaped spaces, separated by the nasal septum, part bone, part cartilage, open at the front via the nares, nostrils, and open at the back into the nasopharynx via the choanoa.
Inside, each cavity has regions. The nasal vestibule just inside the nostril, lined with skin and hairs for filtering. The main respiratory region, largest part, lined with that ciliated respiratory epithelium, rich blood supply for warming and humidifying. And the small olfactory region way up at the apex, with specialized epithelium containing the smell receptors. Projecting from the side walls are the conchae, or turbinates inferior, middle, superior. Bony shelves that create turbulence and increase surface area, dividing the cavity into air channels, meatuses, and the sphenoethmoidal recess, maximizes air conditioning.
And connected to these cavities are the paranasal sinuses. Air-filled spaces hollowed out in the surrounding bones, frontal, ethmoid, sphenoid maxilla. Lined with respiratory mucosa, drain into the nasal cavities, innervated by the trigeminal nerve, Bader, hence sinus pain. Also, the nasolacrimal duct draining tears empties into the inferior meatus, connecting eyes and nose. Other key connections. The cribriform plate on the roof, perforated for olfactory nerve fibers passing up to the brain. The sphenopalatine foramen connecting laterally to the pterygopalatine fossa for artery and V2 nerve branches. And the incisive canal on the floor, linking nasal and oral cavities for nasopalatal nerve, greater palatine artery.
Blood supply here is very rich, essential for warming air, but means nosebleeds, epistaxis, are common. Comes from multiple sources. Sphenopalatine artery from maxillary, greater palatine from maxillary, anterior and posterior ethmoidal from ophthalmos internal carotid, superior labial from facial. That Kieselbeck's area on the front part of the septum is a hot spot for bleeds because several arteries meet there in a rich plexus. Treatment ranges from pressure cautery to packing or even artery ligation in severe cases.
Innervation. Smell is olfactory nerve through the cribriform plate. General sensation is trigeminal, anterior part by ophthalmic V1, posterior part by maxillary V2.
And venous drainage is complex and clinically important. Drains to the pterygoid plexus, facial vein, superior sagittal sinus via an emissary vein through foramen cecum, and crucially the cavernous sinus via ophthalmic veins, another emissary route. Again, reiterating that emissary vein risk. Infections from the nose or sinuses can track directly back along these valveless veins into the cranial cavity, high-risk pathway.
Right, let's move into the oral cavity. Mouth. First stop for digestion, key for speech. Boundaries. Roof is hard and soft palates. Floor is muscular diaphragm, mylohyoid mostly, plus tongue. Walls are cheeks. Opens at the front via oral fissure, connects at the back to pharynx via oropharyngeal isthmus. Two regions. Oral vestibule, between teeth gums and lip cheeks, and oral cavity proper inside the teeth.
The bony framework involves maxillary and palatine bones, hard palate, mandible, lower jaw, sphenoid muscle attachments, and the hyoid bone, base for tongue floor muscles. The mandible has lots of features: body, rami, symphysis, midline fusion, alveolar arch for teeth, mental foramen, nerve exit, mental spines, genial tubercles inside, muscle attachments, retromolar triangle behind last molar, mandibular foramen inside the ramus, entry for inferior alveolar nerve vessels, lingula, flap near the foramen, all important landmarks.
The floor of the mouth is that muscular diaphragm, mainly the mylohyoid muscle, slung between the mandibles, innervated by the mylohyoid nerve from V3. Above it, the geniohyoid muscle, innervated by C1 fibers riding with hypoglossal 12, and the digastric muscle below behind, anterior belly V3, posterior belly 7. Together, these can lift the hyoid, swallowing, or depress the mandible opening mouth. And remember that gateway we mentioned. The gap in the back of the mylohyoid allows things like the submandibular gland duct and lingual nerve to pass up into the oral cavity proper.
The tongue itself, a muscular marvel, highly mobile, speech, taste, swallowing, forms part of the oral cavity floor and the anterior wall of the oropharynx. Has a mobile apex, tip, and a root attached to mandible and hyoid. Surface features: terminal sulcus, V-shaped dividing front 23 from back 13, foramen cecum at its point, embryonic remnant, and papillae covering the surface filiform, fungiform, valate, foliate, increased surface area. All but filiform have taste buds.
And its movement comes from two muscle groups. Intrinsic muscles are within the tongue itself. They change its shape, shorten, lengthen, curl, flatten. Precision movements for speech and manipulating food. Extrinsic muscles originate outside the tongue and insert into it. They move the tongue bodily. Genioglossus protrudes, hyoglossus depresses, styloglossus retresses, palatoglossus elevates posterior tongue.
Tongue innervation is famously complex, reflecting its multiple roles. Motor: all intrinsic and extrinsic muscles are supplied by the hypoglossal nerve, except palatoglossus. Palatoglossus is innervated by the vagus nerve, X via the pharyngeal plexus. General sensation: touch, temp, pain. Anterior 23 by the lingual nerve from V3. Posterior 13 by the glossopharyngeal nerve with a tiny bit of vagus X right at the back. Taste: special sensation. Anterior 23 via chorda tympani from facial nerve hive, which travels with the lingual nerve. Posterior 13, including valate papillae, via glossopharyngeal, IX, again with a bit of vagus X right at the back near the epiglottis. A real mix of nerves converging here.
Salivary glands, digestion's first chemical responders. We covered the parotid already, outside the oral cavity. What about the other two major pairs? Submandibular glands are hook-shaped. Big superficial part sits outside the oral cavity in the submandibular fossa. Smaller deep part wraps around the back edge of mylohyoid muscle to enter the floor of the mouth. Its duct opens at the sublingual caruncle near the tongue frenulum.
And the sublingual glands, smallest pair, almond-shaped, sit right under the tongue mucosa in the floor of the mouth, lateral to the submandibular duct. They create that little ridge, the sublingual fold. They drain via lots of tiny ducts opening onto the fold. Sometimes a larger duct joins the submandibular duct.
And their parasympathetic innervation, stimulating saliva flow, different pathways, parotid, preganglionic fibers from glossopharyngeal, postganglionic via auriculotemporal nerve, submandibular and sublingual, preganglionic fibers from facial nerve via chorda tympani, submandibular ganglion, postganglionic fibers travel with lingual nerve to the glands. Distinct roots.
The soft palate, again, that dynamic barrier, structurally based on the palatine aponeurosis from the tensor veli palatini muscle. 5 muscles control it. Tensor veli palatini tenses it, opens the eustachian tube, innervated by V3 unique. Levator veli palatini elevates it, closes off nasopharynx, innervated by vagus X. Palatoglossus pulls it down, forms the front arch. Palatopharyngeus pulls it down medially, forms the back arch. Musculus uvulae lifts the uvula. All work together to seal off the nose during swallowing. Essential function.
The lips and oral fissure. Enclose the orbicularis oris muscle, plus nerves, vessels, little labial glands, vermilion border, philtrum groove, frenulum inside. Controlled by orbicularis oris sphincter, plus all those other facial muscles pulling on the lips and mouth corners.
And the oropharyngeal isthmus, the gateway from mouth to pharynx, bounded by palatoglossal arches, sides, soft palate top, tongue base, bottom, can be closed by lifting the tongue, lowering the palate, and pulling those arches together, sealing the mouth off.
Finally, teeth and gums. Innervations all trigeminal nerve, V. Lower teeth. Inferior alveolar nerve from V3. Upper teeth. Superior alveolar nerves, posterior, middle, anterior from V2. Gums. Various branches lingual, buccal from V3. Nasopalatine, greater palatine from V2, plus the alveolar nerves themselves. Arterial supply follows suit. Inferior alveolar artery for lower teeth, superior alveolar arteries plus palatine branches for upper teeth, all ultimately from maxillary artery branches mostly. Explains why dental pain can feel quite specific or is sometimes refer along these nerve pathways. Okay, let's focus now on the neck itself, those crucial corridors. It's incredibly complex but organized into compartments, right, like different zones. The visceral compartment holds the pharynx, larynx, trachea, esophagus, plus thyroid and parathyroid glands. Then the vascular compartments containing the carotid arteries, internal jugular veins, vagus nerve, and posteriorly, the vertebral compartment with the cervical spine and its deep muscles, all wrapped and separated by layers of fascia investing, pretracheal, prevertebral, and that important carotid sheath around the main vessels nerve.
And to navigate all this, clinicians rely heavily on the triangles of the neck, essential landmarks. The anterior triangle is that big central area, bordered by the mandible above, sternocleidomastoid muscle laterally, midline medially. Contains those strap muscles, supra and infraoids, the carotid sheath contents, thyroid, parathyroid. It gets subdivided further into submandibular, submental, muscular, and carotid triangles for more precision.
And the posterior triangle is more lateral, bordered by sternocleidomastoid muscle in front, trapezius muscle behind, clavicle below. Key structures passing through here include the external jugular vein, subclavian artery, and critically the nerve plexuses, cervical plexus, and brachial plexus heading to the neck, shoulder, arm. It's also subdivided by the omohyoid muscle into the omoclavicular, supraclavicular triangle below, and the occipital triangle above. Mastering these triangles is fundamental anatomical navigation.
The muscles in the anterior triangle are key players, often grouped by relation to the hyoid bone. Suprahyoids, above hyoid, digastric with its dual innervation V3-ZM, mylohyoid, V3 floor of mouth, stylohyoid 7, geniohyoid C1b at 12. They lift the hyoid, swallowing, or depress the mandible. Infraoids below hyoid, the strap muscles, omohyoid, sternohyoid, thyrohyoid, sternothyroid. They mostly depress the hyoid and larynx. Coordinated action is key for swallowing and speech.
And that carotid sheath, a major neurovascular highway, contains three vital structures bundled together, right? Common carotid artery, internal jugular vein, and the vagus nerve X. And the common carotid artery bifurcation around C3-C4 level is a critical point, splitting into internal and external carotids.
Exactly, and right at that split you have specialized sensors. The carotid sinus, a little bulge, has baroreceptors monitoring blood pressure, signaling via the glossopharyngeal nerve, IOX, and the carotid body, a tiny cluster of chemoreceptors nearby, monitors blood oxygen, CO2, pH levels, signaled by both glossopharyngeal IX and vagus X. Vital feedback loops. The external carotid then gives off all its branches, supplying the neck and face outside the brain orbit, superior thyroid, ascending pharyngeal, lingual, facial, occipital, posterior auricular, superficial temporal, maxillary. While the internal carotid famously has no branches in the neck, ascends straight up into the skull to supply the brain, eye, orbit. Clear division of territory.
The neck is also packed with nerves. The cervical plexus, from C1-C4 ventral rami, gives off those cutaneous branches we feel lesser occipital, greater auricular, transverse cervical supraclaviculars emerging near the sternocleidomastoid midpoint, sensory for neck skin, parts of scalp, shoulder. And the brachial plexus, C5-T1 ventral rami, forms between the scalene muscles, destined entirely for the upper limb, motor and sensory.
Plus, several cranial nerves make important appearances. Vagus X descends in the carotid sheath, giving off pharyngeal, superior laryngeal, cardiac branches, and those crucial recurrent laryngeals. Accessory nerve supplies sternocleidomastoid and trapezius, crosses the posterior triangle, making it vulnerable there. Hypoglossal nerve dives toward the tongue muscles, supplies all but palaeoglossus, has those C1 fibers hitchhiking with it early on to supply thyrohyoid and geniohyoid. And the ansa cervicalis, that nerve loop from C1-C3, supplies most of the infrahyoid muscles. Intricate motor control here.
And the endocrine glands in the neck, thyroid and parathyroids. Thyroid is large, unpaired, sits anteriorly in the visceral compartment. Two lobes connected by an isthmus. Developmentally, it migrates down from the tongue base. Thyroglossal duct remnants can cause cysts, fistulas, or ectopic tissue like a pyramidal lobe. Extremely rich blood supply. Superior thyroid artery from external carotid. Inferior thyroid artery from thyrocervical trunk subclavian, sometimes a thyroid ima artery.
Venous drainage is also robust. Superior and middle thyroid veins drain to internal jugular. Inferior thyroid veins usually drain down to brachiocephalic veins. Lymph drains to paratracheal and deep cervical nodes. And here's that critical relationship again. The recurrent laryngeal nerves run very close to the back of the thyroid gland and its ligaments. Highly vulnerable during thyroid surgery, a constant surgical concern.
In the parathyroid glands, usually 4 tiny yellowish glands on the back of the thyroid, but their position is notoriously variable, developed from pharyngeal pouches, mainly supplied by the inferior thyroid arteries, regulate calcium, Also vulnerable during thyroid surgery due to size and variable location.
Finally, neck lymphatics. Highly organized drainage. Superficial nodes first. Occipital, mastoid, preauricular parotid, submandibular, submental. Each drains specific scalp face areas. All lymph from the head neck eventually drains into the deep cervical nodes along the internal jugular vein. Includes key nodes like jugulogastric, tonsil tongue, and gigolo-omohyoid tongue. These then form major trunks. Left side drains into the thoracic duct, ends at left venous angle. Right poi drains into the right lymphatic duct, ends at right venous angle.
Which makes cervical lymphadenopathy, swollen neck nodes, clinically vital. It's a common sign of local problems, head and neck cancers, infections, or systemic diseases, lymphoma infections. Understanding the specific levels of neck nodes is crucial for cancer staging and treatment planning. Palpating these nodes provides huge diagnostic clues, requires real mastery of the drainage patterns. Okay, we've built this intricate anatomical picture. Now let's shift fully to the clinical crossroads. How do we use this knowledge to diagnose and manage problems in the head and neck? Advanced imaging is absolutely foundational here. It's our eyes inside. CT, computed tomography, is often the first line, the workhorse, especially for head injury. Great for seeing brain tissue, the meninges, acute blood like hematomas and skull fractures. Fast and effective. CT angiography, with contrast, is excellent for spotting things like brain aneurysms.
Definitely the workhorse. But MRI, magnetic resonance imaging, gives unparalleled detail of the soft tissues. Fantastic for looking at the brain parenchyma itself, CSF spaces, the spinal cord, spotting subtle lesions near the ventricles. MRA, magnetic resonance angiography, is great for non-invasively assessing blood vessels like the circle of Willis or carotid artery stenosis in the neck. And MRI is incredibly powerful for stroke evaluation. Using sequences like T2, DWI, ADC maps helps differentiate acute from chronic stroke, guiding urgent treatment decisions. Ultrasound also has its place. Doppler ultrasound can look for emboli in brain vessels or assess neck masses, thyroid nodules, and carotid artery plaque extracranially. In infants, you can even do intracranial ultrasound through the open fontanelles. Plain x-rays, less common now for the head, mainly for initial trauma screening for major skull fractures, but CT gives so much more information.
Head injury and intracranial bleeds, still major causes of death and disability. We distinguish the primary injury, the direct damage at impact, often irreversible, from the secondary complications like brain swelling, edema, and that leads to the critical issue of intracranial pressure, ICP, and cunning. The skull's a fixed box. Anything new taking up space, blood clot, swelling, tumor raises the pressure inside. It gets too high, the brain can get squeezed downwards through the foramen magnum, that's coning, or herniation, compresses the brainstem, fatal if not stopped. There are also congenital issues like Chiari malformation, where cerebellar tonsils herniate down through the foramen magnum from birth.
So elite management of head injury focuses intensely on preventing or minimizing that secondary injury, controlling swelling with things like controlled hyperventilation temporarily, or sometimes corticosteroids, and critically surgically removing accessible hematomas like extradural or subdural clots to relieve pressure, revisiting those bleeds clinically. Extradural hematoma arterial, middle meningeal artery tear, often at the thin chordaterian, classic lucid interval, then rapid decline, subdural venous, torn bridging veins, slower onset, common in elderly infants, subarachnoid, often ruptured aneurysm, sudden severe thunderclap headache. Recognizing these patterns is vital.
Stroke, cerebrovascular accident, CVA, another major neurological emergency, defined as blocked blood flow causing neurological deficits lasting over 24 hours. A TIA, transient ischemic attack, or mini-stroke, has symptoms that resolve within 24 hours, but it's a massive warning sign for a future stroke. Needs urgent assessment. Strokes are mainly ischemic, clot blocking an artery thrombus formed locally, or embolus traveling from elsewhere like carotid plaque or hemorrhagic vessel rupture.
Risk factors overlap heavily with heart disease. Diabetes, high blood pressure, smoking are big ones. Younger patients might have clotting disorders, oral contraceptives, drug use, cocaine involved. Symptoms depend entirely on the brain area affected. Common ones: sudden weakness, numbness on one side, hemisensory loss, vision problems, slurred speech, dysarthria, poor coordination, ataxia, altered consciousness.
Emergency management is all about speed. Urgent CT scan first rule out hemorrhage before giving clot busters, thrombolytics. For ischemic stroke, thrombolytics within that tight 4.5 hour window can make a huge difference. Then further test blood work, maybe toxicology. MRI gives a better picture of the extent of damage, especially for smaller strokes, using those DWI-ADC sequences. Long-term is multidisciplinary rehab, antiplatelet drugs like aspirin, and aggressive risk factor control.
And this brings us back to surgery like carotid endarterectomy, directly applying anatomy. removing that dangerous atheromatous plaque from the carotid bifurcation to prevent emboli causing stroke. But the surgery itself requires meticulous dissection around critical nerves in the neck. We've seen cases where minor nerve trauma during the procedure caused issues. Altered skin sensation, cervical nerves, swallowing palate issues, vagus branches, hoarseness, recurrent laryngeal vagus, shoulder weakness, accessory nerve, tongue deviation, hypoglossal nerve. It highlights why that deep, elite anatomical knowledge is absolutely non-negotiable for safety and good outcomes in this region.
Intracerebral aneurysms, those weak spots on brain arteries, often around the circle of Willis, common sites, anterior-posterior communicating arteries, middle cerebral branches, basilar tip, PICA arteries, huge risk of rupture. Presents with that thunderclap headache, stiff neck, vomiting. It can be fatal.
Diagnosis starts with CT to see the subarachnoid blood. Definitive diagnosis and planning needs cerebral angiography to map the aneurysm precisely. Treatment is highly specialized. Either open surgery to clip the aneurysm neck, or endovascular coiling, packing the aneurysm with tiny coils via catheter to make it clot off. A classic presentation pointing towards an aneurysm. Think posterior communicating artery aneurysm pressing on the oculomotor nerve. Causes ipsilateral third nerve palsy pupil dilation, eye deviates down and out, often painful. An immediate red flag for an experienced clinician.
Pituitary tumors, too, like macroadenomas, can cause hormonal symptoms like abnormal lactation, missed periods due to high prolactin, and critically, visual problems. The classic is bilateral temporal hemianopia, losing peripheral vision on both sides. Why? Because the tumor grows upwards and compresses the optic chiasm where the optic nerves cross.
MRI confirmed the diagnosis, shows the tumor size and position. Treatment might be drugs to shrink it or surgery. Often transsphenoidal surgery going up through the nose and sphenoid sinus to reach the pituitary. But again, extreme care is needed. The pituitary sits right between the two cavernous sinuses, packed with the internal carotid arteries and cranial nerves, the third, 4, V, and 6. Damage during surgery has severe consequences. Demands precision based on deep anatomical knowledge.
Thyroidectomy, removing the thyroid gland. Common surgery for goiter or cancer, but carries specific risks tied to the local anatomy. Risk of damaging the tiny parathyroid glands hiding behind the thyroid can cause low calcium, hypocalcemia, leading to tetany tingling, muscle spasms like Chvostek's sign, usually temporary, but needs careful management.
And the big one, recurrent laryngeal nerve injury. We've stressed how close these nerves run to the thyroid. Damage causes vocal cord paralysis, unilateral or hoarse voice, bilateral potential airway emergency. Avoiding this is paramount during thyroid surgery. Requires meticulous identification and preservation of the nerves. Elite surgical skill needed.
Finally, head and neck cancer, mostly squamous cell carcinoma, arising from the lining of the mouth, throat, larynx, sinuses. Major risk factors are still smoking and heavy alcohol use. Prevention is key, but increasingly viruses like HPV, human papillomavirus, and EBV, Epstein-Barr virus, are recognized as significant causes too, especially for certain types like oropharyngeal cancers. Understanding these changing risk factors is vital. #outro. Wow, okay. That was quite a journey through the head and neck, incredibly detailed. From the skull's protective design and those clever fontanelles to the delicate meningeal layers, the CSF flow, you really see how interconnected it all is. Bones protecting, nerves communicating, vessels nourishing, senses gathering information, and how understanding just one part really does illuminate the whole system. The eyes, the ears, the pharynx, larynx, mouth, all working together, breathing, swallowing, speaking. Amazing design.
It truly is. And as we went through all those details, the precise map of the trigeminal nerve, the vulnerability of the recurrent laryngeal, the pathways for CSF flow or infection spread, it just hammers home that real mastery here comes from appreciating that intricate dance between the pure anatomy, the physiology, and how things go wrong in pathology. Every detail, from the massive foramen magnum down to the tiniest emissary vein, carries profound clinical weight. Hopefully this deep dive into your sources hasn't just given you information, but a real foundational sense of how professionals use this knowledge, how these clinical insights let us tackle real-world health challenges, moving beyond just knowing what to truly understanding how and why. That's the elite level understanding.
Absolutely. This kind of deep foundational understanding is just so powerful. We really hope you'll take some time to reflect on all the complexity and connections we've unpacked today.
So thinking about the body's incredible resilience and elegant design in this incredibly delicate, absolutely vital region, what's the most surprising adaptation or ingenious feature you've encountered today? And based on this deeper understanding, what new questions does it spark for you about the future, about medicine, maybe even bioengineering in the head and neck? Something to ponder.